Fred, and then moving on to you two. Okay. अस्सलाम वालेकुम एवरीवन। ICI पाकिस्तान की तरफ से आप सबको खुश आमदेद। Thank you so very much, especially our kind speakers, जिन्होंने अपनी practices और clinics से they were able to take out time and be a part of this program today. I'll be introducing them very shortly. Before we start the program, some meeting guidelines. If you're connected through your cell phones, your laptops, please, stay on mute. And there will be an option for question and answer in the chat box where you questions. When talking about ICI, ICI has existed in this region since even before the inception of Pakistan. And ICI has been involved in various businesses, including soda ash, polyester, chemicals, agricultural sciences, pharmaceuticals, which we are representing today, and animal health. So pharmaceuticals के हवाले से अगर हम बात करें, pharmaceutical medicines में ICI is present in all therapeutic areas which are important for surgery and medicine, including pulmonology, gastroenterology, cardiology, cardiometabolic diseases, nutraceuticals, supplements, urology, general surgery, transplant surgery, etc., so on, and pediatrics. आज हम urological bladder issues और cancers के बारे में बात करेंगे, and we have with us very renowned surgeons, जिसमें सबसे पहले Professor Fred Widges शामिल हैं. Thank you for being a part of this program, and he is an oncological urology professor affiliated with Radboud University. He has a keen research interest in translational medicine and bladder research. And along with that, he is a reviewer and editor of many accredited journals. Along with him, we have some very renowned faculty from here in Pakistan, namely Professor Dr. Hamad Athar, who is the professor in Department of Surgery at AKU and a consultant urologist. He is a very renowned name, and it's a pleasure to have him here with us for this talk. Along with him is Professor Hafiz Qureshi, who has done his fellowship in uro-oncology and is part of the Indus Teaching Hospital, and he will be joining us as well and giving his views about bladder cancer issues. इसके साथ साथ मैं आप लोगों को एक और चीज़ रिमाइंड कराता चलूँ कि CME credit hours आपके लिए अवेलेबल होंगे, and you can use the Google form that will be shown in the chat box on your screens to fill it in order to acquire these hours. Thank you. And moving forward, I would invite Professor Widges to do his talk and share his experience and details with us. Hi, can you hear me?
Yes, I can. I will share my screen.
Sure.
Okay. Can you see my screen?
Yes,
we do.
Yes. Okay, great. So, of course, I would like to thank the Think Health 21 organization for the invitation. Of course, I would have loved to be in Pakistan, but in the circumstances currently, that of course is quite difficult. And I'd like to thank Dr. Abdul, who has been a fellow in my hospital and a good friend for doing this together with me, and Professor Hamad Athar also to be present here and to do this together with me. I will talk about guidelines in non-muscle invasive bladder cancer and bladder cancer, but also more specifically things that I think maybe should be different, or maybe you could avoid doing. So the title is actually when the guidelines are or can be ignored, because of course, sometimes you don't have to or you can't follow the guideline. I have some conflict of interest, but not relevant for this lecture. And I will be talking about European guidelines. This is the non-muscle invasive guideline that has been published in European Urology in 2019. But of course, you can also look at the website for the EAU where you can find the guideline. There is a lot of non-compliance. This is, I admit, this is an older study published in 2011. But here you can see that if you take together everything that should have been done according to the guideline, like treatment, like follow-up, you see here that of 4,500 patients, only one had all the guideline recommended measures. And the reason for that is actually you and me. We as a urologist, as a surgeon, don't follow the guideline very well. That's of course actually not what should be the case. So it's usually a surgeon decision, sometimes correct, sometimes not correct. And if we now go for more specifically and more recent, a recent publication from last year, European Urology, Urological Oncology, you can see here that, let's say, around 50% or less of the guideline advices are followed, so the compliance remains low. And I will talk about these issues a little bit one by one. Let's start with the single postoperative installation that we should do after a transurethral resection for a low or an intermediate risk bladder tumor. You know, there is a large update from Richard Sylvester, the old statistician of the ORTC. He looked at all the studies present, 11 studies, more than 2,000 patients. And yes, if you give in low-risk patients a single post-op installation, you will reduce the 5-year recurrence rate significantly, around 15%. And that is also clinically relevant. You should do that on the day of surgery. All drugs are equally effective. And of course, you have to make sure that it is safe. There shouldn't be a TOR perforation. On the right upper hand, you see one of the issues that you might encounter. If you then look after 3 months into the bladder, you very often see a large calcification, which patients normally don't have any complaints of, but that's something you should know. So the conclusion of the single post-op installation is it works, it is safe, so follow the guideline. But it's not done a lot. The simple alternative would be, and I sometimes do that when my patients have an allergia for mitomycin C or other things, you can give continuous bladder irrigation for around 24 hours for 1 day after the TUR. And that actually also is safe and it has comparable efficacy. So that might be an alternative. What about instillation therapy, chemotherapy or BCG in intermediate risk patients? And I don't know how the situation is in Pakistan, but I know in the United States and Europe, there are problems with availability of BCG. So this is something the International Bladder Cancer Group, which I chair together with Ashish Kamat, has come up with a few years ago. If you look at the intermediate risk group, which is a large group, there are some factors that can help you to decide to give therapy. And that is the number of tumors, the size of the tumor, smaller and bigger, the time to recurrence, larger or shorter than 1 year, and the frequency of recurrence. And of course, this makes sense. And you already understand, and you only have none of these risk factors. It still is intermediate risk, but you might give only a single post-op installation. If you have a few risk factors, probably you should best give chemotherapy, for example, mitomycin C. And beware, if you have 3 or more of these risk factors, that actually is almost close to higher risk. So probably this is a case to give BCG. So you can already differentiate treatment in this group by looking at additional risk factors. And something that I'm opposed to already for decades, that is re-TOR, which you have to do standard in all patients. You see less than 50% of these high-risk patients in this guideline review had a re-TOR. What do I teach my students? What do I teach my residents? If there is any doubt about your TOR, then you have to do a re-TOR. For example, if you are in doubt about a complete resection, sure, do a re-TOR. If you are in doubt about an adequate deep biopsy, of course, you have to do a re-TOR. And if your histology reveals a T1 tumor, but you don't have detrusor, so that's the result of your pathologist, that's not correct. You have to do a re-TOR. And if you have high-grade cytology and your pathology reveals a low-grade tumor, that's also not correct. So you have to do a re-TOR. Because if you do a re-TOR in everybody, the downside is that you might postpone effective therapy for 4 to 6 weeks, which is BCG. This is also very elegantly been shown by Tuoda Quintero. He has a database of 2,500 patients, high-grade T1 patients with or without detrusor present. And he very clearly has shown that the VTOR is only important, it only impacts on prognosis if there is no detrusor present, which makes sense. So if you have detrusor is negative, you have a high grade T1, please start with BCG and don't wait too long. Okay, then look at another issue. High risk patients, highest risk patients, the advice is to do a cystectomy. 1/3 of those patients had a cystectomy. And if you look at the guideline, European guideline, and the alternatives that are mentioned, then there are a few. You can give intravesical chemotherapy if a patient is failing on BCG. Here you see a rather older review which looked at gemcitabine. That's one of the things that we have been using in the Netherlands in those patients that, in the cases that we had BCG unavailability. Gemcitabine 2 grams in 50 ml is effective, but also quite acidic, so it's not very nice for the bladder. So this is an alternative. You might have seen this Journal of Urology article last year, where a retrospective study from America showed that the combination of gemcitabine and docetaxel, so 1 gram gemcitabine for 1 to 2 hours, and after that 37.5 milligrams of docetaxel intravesically, also for 1 to 2 hours, had a very nice recurrence-free survival in these high-risk patients. And yes, it's retrospective, of course, it's not randomized, but still there are some alternatives with chemotherapy if you don't have BCG. And I'm quite sure that Professor Amat will also talk about this. Then you have microwave-induced chemohyperthermia, and I have a bias because I've been doing this now for 20 years. This is one of the studies that we've done. We compared BCG to Senago treatment, and Senago treatment really was better with regard to recurrence and progression. Now the question is, why doesn't everybody do that? Because it's quite expensive and it's not reimbursed, but we still do that in my hospital. And here we looked at some patients that were BCG unresponsive or BCG treated or BCG naive. And you see that even in the worst group, the BCG unresponsive group, the overall survival and the cystectomy-free rate is 3/4, so around 70–75%. So if you have some kind of hyperthermia treatment available and preferably radio frequency induced, this is certainly something to keep in mind. Then, you know, electromotive drug administration has been used, but I know the data are quite limited. There has been a recent Cochrane review in 2017 actually showing that it is not really that much better. And even if you have that, you still have to use BCG. So for BCG unavailability, this is not an option. And finally, of course, the new stuff, immunotherapy. We've been treating bladder cancer with BCG since 1975. That is also some kind of immunotherapy. And if you look at systemic immunotherapy, there are a lot of trials that are ongoing or have been finished. You know that the Keynote 57 trial with pembrolizumab has shown in BCG unresponsive patients a quite reasonable success rate. And you see here the reason why bladder cancer might be an ideal candidate, because you have a quite high mutational load in bladder cancer, just like in melanoma and in lung cancer. Whether this will be the answer in the long run, because this is probably done by the oncologist, I don't know, but it's certainly something to keep in mind. Mind you, all these mentioned alternatives have less experience or very few experience, and it is still considered oncologically inferior. Last remark on the non-muscle invasive bladder cancer guidelines, something that I'm also already fighting for years. I think one of the most important factors for prognosis in T1 is the subdivision of T1A, T1B, and T1C. So if you have a deep infiltrative T1 tumor, it certainly has a much worse prognosis than a superficial T1. You can see in the graph here below that the T1B/C classification was the most important factor for progression, even more important than presence of carcinoma in situ or lymphovascular invasion. And the funny thing is, it's still not in the guideline, whereas CIS is in the guideline and lymphovascular invasion is also in the guideline. Let's switch to muscle invasive bladder cancer. And again, this is a publication of this year on the muscle invasive bladder cancer guideline of 2020. And I'm able to chair that, which is very nice to do. Let's do something, neoadjuvant chemotherapy. If you look at the summary of evidence, you see that the summary of evidence actually is quite good. And if you then look at the recommendations, they're all strong. So you have to offer neoadjuvant chemotherapy for T2 to T4 clinically and 0 M0 bladder cancer, always use cisplatin. Don't do that if there is cisplatin ineligibility, and then you might offer, but that's still more or less in research, neoadjuvant immunotherapy. So neoadjuvant chemotherapy really seems obvious. But there are really limitations to neoadjuvant chemotherapy. One, the results apply to urothelial carcinoma. And we see, at least I see, variant histology more and more, all kinds of strange tumors, and we don't know what to do there. Second thing, can we predict response? Markers might be coming. What has been shown to have some impact in cisplatin-based neoadjuvant chemotherapy is defects in DNA repair genes, but that's obviously not something that you're going to do in every patient's in everyday practice. Maybe imaging. You know that there has been a VIRAS system, and of course it's difficult, but you can see here on the pictures that, for example, the differentiation between a T1 tumor and a T more than one tumor is quite easy. So in follow-up, you might use maybe MRI in the future, something that is, I guess, unexplored, or at least not explored enough. What about patient selection? Guys, if I look at United States, if I look at Europe, if I look at my own country, a lot of those patients have problems. There is cis ineligibility due to impaired renal function. You see that around 50% of patients don't have enough renal function to get cisplatin. Impaired performance state. Most patients are older, are not very skinny, have been smoking. And for example, the average age for bladder cancer in the Netherlands is 73. So that's your mean age. So it's not an ideal group to give heavy chemotherapy. And so you see that even if you are able to give chemotherapy in that 50% of patients that might be fit enough, you see in this review that almost 30% of those patients that did get chemotherapy, so they were considered fit enough at the start, did not complete the chemotherapy regimen, because still it is a very heavy schedule. MVAC, GemCis, very heavy schedule. Then these results, you have to realize that, have been based on older trials, EORTC trials from the 80s and the 90s. And I've been part of those trials. And they're good trials, but I think we're now 20, 30 years later, there are some changes that might be important. For example, all these trials have been actually based on the use of MVAC. And I think what we use currently, GemCis, is maybe a little bit less effective. And I've been operating in the 90s. I'm still operating. I really think that from an operative point of view, we do a more radical, from an oncological point of view, operation. So we do a better, more extended node dissection. You see a review that we did with the guideline panel, and there are some data that support the extended node dissection. It's a level of evidence 3, so it's not very, but still, you know, it makes sense that if you do a better operation, you will have less recurrences. Anyway, you have to do a node dissection if you do a cystectomy. That's a strong recommendation. And here you see the only trial that is currently available. The American trial has not been published yet. This is the German trial, and you see indeed that if you have a extended or non-extended node dissection, the prognosis is obviously almost the same, only in a subgroup of T2 tumors, the extended node dissection did better than the non-extended node dissection. So take out of this what you'd like. I think an extended node dissection certainly makes sense. So my thoughts on neoadjuvant chemotherapy. So I oppose to my own guideline. Studies that have been used are from the 90s of last century. In 2021, I think we operate more effectively. We might give a little bit less effective chemotherapy. So I wonder whether we would get the same, let's say 5 to 8% advantage in overall survival in the current era. I think it would be more than 2 to 3% and only in higher stages. And for me, that is the reason not to offer neoadjuvant chemotherapy in limited locally advanced disease, so clinically T2, provided you do a good node dissection. And realize patients that do not good on neoadjuvant chemotherapy have a worse prognosis. You see here, if you still have more than PT2 at radical cystectomy after neoadjuvant chemotherapy, you don't have a very good prognosis. So you delay effective surgery in those patients that do not respond, and certainly not everybody responds. So what kind of cystectomy? I don't know how many robots you have in Pakistan. We have a lot in the Netherlands. If you look at the guideline, the actually advice is quite clear. Basically, select an experienced surgeon, an experienced center, but there's no real advantage of open or robot cystectomy. They both have their issues, they both have their advantages, they both have their disadvantages. So you don't have to really promote the robot that much. That you can also see from the review of all the 5 randomized controlled trials that have been done. There's no difference in complication rate. There are some less blood transfusion after a robot, a marginally shorter hospital stay, it's less than a day, but longer operative time, it's more expensive, and there is no oncological difference. So the surgical approach does not have a considerable impact on oncological safety and quality of life endpoints and outcomes. Do we always have to do surgery? I told you a lot of those patients have pulmonary problems, hypertension, are old, are fat, do smoke. So are there alternatives? If I look at the Dutch situation, you see that even below the age of 75, certainly not everybody gets a cystectomy, 60 to 80% in the last few years. And above the age of 75, it's even less, around 40% of patients get a cystectomy. So there have to be alternatives. And yes, there are. You see that the recommendation, the guideline is that the strong recommendation is to do a cystectomy, sure, but you also have to discuss potential alternatives. So which alternatives are mentioned in the guideline? Potential alternatives are only a TOR, you should do that. Only radiotherapy, you should not do that. Or only chemotherapy, you should not do that. The strong recommendation that it is not enough. Sure, maybe for palliative reasons, radiotherapy, but that's different. But the combination of these 3, so multimodality or trimodality treatment, is a strong recommendation as a in well-informed patients as a good alternative for cystectomy. You also need compliant patients because you still have to do lifelong follow-up. If you do trimodality therapy, which is the form of bladder preservation, it includes, like I told you, a radical TOR, a radical as possible TOR, chemotherapy as a radiosensitizer, so it's not neoadjuvant chemotherapy, and of course radiotherapy. And selection is a very, very important issue. You should probably have smaller invasive tumors which you can resect very well, no carcinoma in situ, and no hydronephrosis. And if you look at the recommendation in the guideline, you can see here that indeed absence of carcinoma in situ is important, good debulking surgery is important, and the absence of hydronephrosis is important. But if that's the case, then there's still quite strong strength rating that trimodality treatment might be a good alternative. And then partial cystectomy. I told the other 2 guys that I was invited to Indonesia 2 weeks ago, also virtually online. And I was supposed to give a lecture on partial cystectomy. And to be honest, I never do that. So I looked at EU guideline, not one word on partial cystectomy, because that is bladder sparing. And I see here, and I told you what are the bladder sparing strategies. I looked at the AOA guideline, and there it said that partial cystectomy is something with an associated increased risk of all-cause mortality. So it's less effective than a radical cystectomy. So I looked into the literature, and there's not that much literature. Most is also older. But you see that there is a renewed interest in bladder sparing strategies. I also see that on congresses discussing, for example, trimodality therapy. If you look in the literature, still there are some cystectomies that are done partially, 7 to 10%. Recent series, and that's again not that recent, but still recent series find a comparable survival as a radical cystectomy, but there is of course an enormous selection. And that includes salvage radical cystectomy in case of recurrence. And if you consider partial cystectomy, you should also do an extended pelvic node dissection. Obviously, one of the advantages is that you have much lower complication rates because you don't use bowel. You see here the complication rate after cystectomy is, of course, considerable. We know that. If you don't use bowel, the complication rate is much less. And again, it's very, very important to select the correct patients for that. The ones with prior urothelial carcinoma, lymphovascular invasion, need for urethral reimplantation are not good candidates. So a good statement is that the tumor should be solitary in space. So it's the first one. Solitary in time, resectable without carcinoma in situ. Then maybe partial cystectomy might be a good indication. I, by the way, do that sometimes for a uricus tumor or for a tumor in diverticulum. So my last two slides, take-home messages for non-muscle invasive bladder cancer. Always follow the guideline, but think about 24-hour bladder irrigation instead of a single post-op installation when you have a good reason for that. Differentiate intermediate risk non-muscle invasive bladder cancer based on some factors to decide between single post-op installation, mitomycin C, or BCG. Think about the re-TOR. It's not always good. Think about lymphovascular invasion in high-risk patients. That is important, just like the T1 subclassification. And there is more than BCG. And of course, that will probably be discussed anyway, certainly a case of shortage. Take-home messages for muscle-invasive bladder cancer. Always follow the guideline again, but consider neoadjuvant chemotherapy in case of clinically T2 and M0 patients. Beware that if you don't respond, the patients will have a worse survival. Consider an extended node dissection if you do cystectomy. Don't push to the robot. There's actually not a real advantage. It's only very expensive. And think about bladder sparing. Radical cystectomy is not that gold of a standard. Having said this, I think I'm going to end my lecture. And if there are any questions, I'd be happy to answer them.
Thank you very much, Professor Ridges. It's really wonderful hearing you after some time. And obviously, there couldn't be anyone better than yourself to address these issues. You're greatly involved in creating those guidelines for us. And we're really very, very grateful. I have a few small questions for your consideration. Do we have, or we can still say there is one molecular marker that you would like to pursue in your clinical evaluation of patients with non-muscle invasive bladder cancer in terms of follow-up and subsequent intravesical treatment?
I think if you, to decide on treatment, I guess that's most of an issue in high-risk patients. And then for me, if I have a T1 high grade, I do look at gender. So if females have a worse prognosis. I do look at lymphovascular invasion, and I do look at the PT1 subclassification. That's really something that you know from the patient, or your pathologist should be able to provide without any problems, because it is quite easy to get that information. And if that's all present, I'm a little bit scared, and you might already go quite soon for radical cystectomy in T1 high grade. So there are no, currently at least, no molecular markers, maybe you're referring to that, like the basal, that thing. There are no molecular markers which I use to decide on therapy. It's still mostly clinical. For example, in invasive tumors, also the PD-L1 markers don't give a lot of answer to decide on kinds of therapy. And a follow-up, maybe that's something that you mean. I've been now using one marker, to skip part of the cystoscopies in follow-up. There are now several markers that have been tested, that have been published, that have a very, very high negative predictive value for tumors. So if those markers are negative, the chance that the patient still has a tumor or recurrence in the bladder is low. It's 1% or less. And the logistics are very simple. You don't have to travel, which is important now in the corona time. It's more patient convenient. It's not very expensive. So I've been using now a few markers in research, and from a clinical point of view, I'm now using the APICheck marker for patients in follow-up of non-muscle invasive bladder cancer. And if that's positive still, you can still do a cystoscopy, but that's the only marker that I really use as a marker, and in this case, only in follow-up.
Thank you very much. It's interesting that you pointed out that the gender has an impact. EORTC table compared to the Kyoto table does not have gender. Do you think that the gender could be included in the future EORTC risk calculators? And does the site of tumor, the proximity to the trigon, another important factor that could potentially be added to the EORTC table calculator?
So the EORTC calculator obviously is for non-muscle invasive bladder cancer, and you know that there is a very No, I've seen the review. No, I've seen the article in the May issue of European, in the March issue of European Urology. There is an update of the calculator, but which still, you're right about that, doesn't include gender, and it doesn't include the side of the recurrence or the tumor. I know from the time that I was still actively involved in the ORTC that we have been looking at the side of the tumor. We haven't found that as a very important prognostic factor, but maybe that is because it's sometimes difficult to differentiate. You might call something side wall, which I might call the back wall or the dome. So that's not always very easy. I agree with you that I have the gut feeling that trigonal tumors and tumors near the ostia do worse than a tumor in the dome. I really think that you're right about that, but there haven't been large studies that have proven that it is the case. And gender is an invasive bladder cancer, a limited prognostic factor. Reason is quite simple. The bladder wall of males are, almost a centimeter. In older males, the bladder wall of females still is quite thin. So they have easier and quicker an invasive tumor and a T3. There are some new reports that say that the disadvantage in prognosis is only for the first 2 years. After that, women do the same. And I think that's more or less also because there is some delay in diagnosis. But it's not in the guideline. For me, it is certainly a factor that I take into account when deciding on what to do.
Thank you very much, Prof.
Thank you. Thank you so much, Professor Pedres, and for such an elaborative and educational talk. It has been a pleasure, and it has really been a good learning session for all of us here and the participants included. So now I would like to call upon Professor Hamad Athar. Assalamu alaikum, sir. To talk about BCG and beyond in NMI for bladder cancer.
Right. Thank you very much to ISI for this very kind invitation. And it's a real honor for me to be talking about the BCG and some of the recent advances in the treatment of non-muscle invasive bladder cancer, which is not responsive to BCG. And I will be mostly quoting Professor Vijay's work on this. So he's one of the biggest authority on this area. So it's a real honor for me to be present in this meeting. So I have no conflicts or affiliations. The story of BCG started exactly 100 years back when Albert Calmet and Kamal Guerin in the Pasteur Institute isolated from Mycobacterium bovis the BCG vaccine. It took them 13 years between 1908 and 1921 to isolate this vaccine for tuberculosis, and it was administered in children who are at risk of developing tuberculosis. And this cartoon of Albert Calmet is still probably hanging in the Pasteur Institute in Delillet. So we owe a lot to these two gentlemen for the excellent work and this excellent medicine that we have at the moment. Well, the story of BCG is much older than Albert Calmet and Kamal Guerin. There was this American surgeon who used what is called the Cooley's toxin, William Cooley from New York, and he used it for lymphosarcoma. And this Cooley's toxin was essentially from the deactivated Streptococcus bacteria, the toxin obtained from that, and Serratia, which was not known to be called Serratia at that time, but Serratia that we know now. And he used it for the treatment of lymphosarcoma, which were inoperable and could not be taken care of surgically. So this was in the 19th century, really in the late 19th century. And he's truly called the father of immunotherapy. From that point onwards, it was observed by Pearl and colleague about 70, 80 years back that patients who've got tuberculosis are less likely to have advanced malignant neoplasms. So tuberculosis is in a way providing some form of an immune response which can fight against cancers. Mathey et al. In late 1960s used BCG along with chemotherapy for the treatment of cancer, but he observed that not all patients respond to this treatment. And subsequently, Zabar and colleague created what is called the Zabar's rule. And the Zabar's rule was that the tumor should be localized as small as possible and in direct contact with the BCG at a concentration of 10 raised to the power 6 to 10 raised to the power 8 colony forming unit in order for the BCG to work against the cancer. And this concept was picked up by Alvaro Morales, the Canadian urologist who has done the pioneering work and published his work in 1976 in the Journal of Urology. And that's the time from when we have this wonderful drug available for the treatment of very aggressive non-muscle invasive bladder cancers. So we owe to Alvaro Morales for that pioneering work. We know that BCG has millions of doses have been administered with all that shortages, and still it's one of the most reliant drug for the treatment of non-muscle invasive bladder cancer. We still don't know much about how it works, and there have been theories. We don't know the precise way BCG works. We know that it attaches to the urothelium using fibronectin and integrin. Then it is incorporated by the tumor cells. It creates immune response. We know the same cascade of events, which is known for various immunological events. And probably this is the way it kills the tumor cells. But we don't know the precise mechanism. And if we are able to find out the precise mechanism, we probably may be able to predict which patient will respond and which would not respond to the BCG treatment. So BCG is indicated, as pointed out by Professor Widges as well, for high-risk carcinoma in situ patients, multifocal recurrent, be it first-time patients or naive patients, versus also patients who have had the induction treatment, and they can be re-inducted and started on maintenance treatment. So these are some of the known indications which are there in our guidelines as well. I'm just sharing a few cases. And this is case number 1, 63-year-old male, 30-pack year history of smoking, large volume bladder tumor, and had 2 TURs with incomplete resection. Typically not a candidate for BCG. And the reason why it is not a candidate that it has an incomplete resection. So you would not give BCG, you probably have to think of something else, because unless you create a totally clear bladder, BCG, and I would like Professor Widges' comment subsequently if my assessment is incorrect. Another patient, a 56-year-old gentleman, 20-pack year history of smoking, had a TURBT for an isolated 4 centimeter posterior wall tumor. His histopathology came as T1 high grade. He also had a suspicious hyperemic areas in the prostatic fossa. The prostatic biopsies were done, and it showed prostatic stromal invasion. Again, in my opinion, prostatic stromal invasion, again, is not a situation where you would probably use BCG. Although this patient, if we take the prostatic stromal invasion out, is an ideal candidate for BCG treatment. Another lady, 67 years of age, gross painless hematuria, had a complete resection of an anterior and lateral wall tumor about 6 centimeters. Her histopathology showed a poorly differentiated non-muscle invasive urothelial cancer invading the lamina propria with a micropapillary component. Repeat TUR showed no muscle invasion, and she was considered for, and she was very keen to save her bladder. But again, there is very little current evidence supporting use of BCG in this scenario. So why BCG or any intravesical treatment is being used for a non-muscle invasive cancer? We know that the 2 major problems with NMIUC is recurrence rate and the progression rate. So both of them and have been shown by some excellent work and meta-analyses of some of the nicely designed randomized controlled trial. And we have a level 1A evidence that intravesical BCG compared to TUR alone significantly reduces the recurrence rate of non-muscle invasive bladder cancer. And similar evidence is available that it affects the progression. The question is, which strain of BCG? We know at least there are 10 strains of BCG available. And if you look at this world diagram, you can see that it is variously colored. And these are the various areas using different types of strains of BCG. Is one strain better than the other one? We don't know. And the current evidence indicate this is a large phase 2 trial, which clearly shows that no one strain has a superiority over the other one. Second question about the use of BCG is how long? And we know that various studies looking at induction plus some suboptimal BCG maintenance have consistently shown that the recurrence rate and progression rate is no different between BCG alone, the TUR alone versus the suboptimal BCG maintenance. It was the EORTC 30962 trial, which showed that the 3-year maintenance, both for papillary tumors as well as for carcinoma in situ, with 3 weekly at 3, 6, 12, 24, and 36 months is the regime to follow for the most effective use of BCG. And I'm quoting here against Professor Vijay's and Ashish Kamat's work here, that this review in European Urology some years back, that can you decrease the dose and be still effective? Well, there is evidence to show that for intermediate risk tumor, you can decrease the dose of BCG by 1/3 or 1/2 and be still effective in decreasing to a certain extent and improving the safety profile of BCG. However, for multifocal tumors, there is very little evidence to support that decreasing the dose could be is a right choice to make. So the conclusion from this article and review by Professor Vijay shows that full dose BCG is not necessarily in all patients, and lower dose, 1/3 or half dose can be used for intermediate risk cancers. What about prostatic urethral CIS? Again, that's a difficult disease to treat. Majority of these patients cannot have, and not majority, none can have an orthotopic new bladder. So they would be requiring some form of incontinent urinary diversion, something that people really don't like in part of the world. I have used in small series of patients, and there is some data also supporting that a TUR creating incompetent bladder neck and using BCG is one effective treatment which can be used in patients who are really keen to have their bladder preserved. Now, the BCG is obviously fails in certain patients, and we don't know which one will fail, but we know, and we now speak a uniform language when we talk about the failure of BCG. And again, this all-star authorship of this article in Journal of Clinical Oncology with one of the biggest names in non-muscle invasive bladder cancer are there, which are our magician, mathematician, Richard Sylvester as well. And they have defined very clearly, and so we all speak now very uniform language, what BCG refractory cancer is. And we need to be very careful about whenever we define this, that we need to talk about high-grade recurrence, and we need to talk about an optimum BCG, which is at least 5 induction and at least 2 maintenance cycles before at 6 months we can say that the patient is refractory to the BCG. Obviously, any TA recurrence at 6 months is something that you don't really need to worry about and go on and resect it or burn it and continue with your maintenance. BCG relapsing, again, is somebody who has initially responded to and subsequently develop a recurrence of disease. This BCG and unresponsive tumors is a combination of BCG refractory and BCG. So great work by these gentlemen in defining and giving the uniform terminology to these things. Now, what's the treatment for BCG unresponsive or tumors? Well, the standard treatment is radical cystectomy. And obviously, it is oncologically extremely efficient treatment to take care of their bladders, because timely cystectomy is what people need if you have a BCG unresponsive disease. But understandably, in a small group of patients, this is an overtreatment. And some of these patients probably could have saved their bladders. So we need to look at some of the alternative treatments that are available. We're going to just quickly point out, for the sake of time, some of the things which are available at the moment. So radical cystectomy for non-muscle invasive bladder cancer is a valid indication. And we know that we often, even with re-TUR, sometimes miss out a non-muscle invasive bladder cancer, which we see on subsequent cystectomies. We know that if your patient with non-muscle invasive bladder cancer progresses to muscle invasive bladder cancer, he or she is likely to have a more aggressive disease compared to patients who have de novo muscle invasive bladder cancer. So for all these reasons, non-muscle, if there is a proper indication for cystectomy for non-muscle invasive bladder cancer, it should not be delayed. And we know that this old paper by Ganzinger et al. in European Urology clearly showed that early cystectomy versus deferred cystectomy have very different disease-specific survival. So we need to be very, very careful in doing a timely cystectomy for these patients who are not responding to our TUR and intravesical treatment. So what alternative options are available? We know that we have new chemotherapy, and some of these are alluded to by Professor Widges as well. We have chemotherapy combinations. We have various ways of drug delivery, and radiofrequency and EMDA and are some of the modalities. Unfortunately, none of these things are available in Pakistan. So really we are short of options. Gene therapy, immune checkpoint inhibitors, vaccines, oncolytic adenovirus, etc., are some of the modalities available. I'm just going to very quickly touch upon two things which have come up in January 2020 and January 2021, and what is the Keynote 057 trial and subsequent FDA approval for pembrolizumab for the treatment of BCG failed patients. And we see that about 40% of patients can probably, at least on the short term, be able to save their bladders if they have failed BCG and have received pembrolizumab. How the immune checkpoint inhibitors work, it's really very interesting that cancer cells develop mutation that can make them foreign to the immune system. And T cell recognizes and attack these foreign cancer cells. These cancer cells can evade immune attack by expressing PD-1 and PD-L1. And it is blocking these PD-L1, which will be instrumental in letting the immune system take care of the bladder cancer. So the other one is the nadofaragene firadenovec, something which is a very, very recent thing. And this is a non-replicating recombinant type 5 adenovirus vector-based gene therapy, which delivers human interferon alpha-2b gene to the cancer cells. The mechanism, I'm not going to go into the trial. The outcome is very similar to what we have achieved with pembrolizumab, but probably the only difference is one is systemic treatment with significant systemic side effects as well, compared to the intravesical treatment, which is the nadofaragene firadenovec. And we see that about 30 to 40% patients will be able to save their bladders, at least for the first year after treatment. So we're still waiting for long-term outcome of these interesting new treatment. The mechanism is quite interesting, that you remove the replicating part of the genome, you insert the genetic material that has to be transmitted, and add an excipient. These viruses will then be introduced into the bladder, and then the immune system gets activated, and these are directly delivered to the cancer cells. The anti-tumor activity coming from anti-proliferative, the TNF-mediated cytotoxicity, and the antigenic. Some of the other things which are available, and there's some literature, but again, whatever clinical evidence, whatever trial evidence we have is again for a short period of time. These are expensive modalities, and in the words of Professor Shahrukh Shariat, that any treatment which is for BCG failure has to be as effective as radical cystectomy, and it should be effective for a period of time before it can be taken into clinical practice. So with these words, I would like to end my presentation on, again, quoting the EAU guidelines, that radical cystectomy is the treatment of options for patients who have failed BCG. Clinical trial is another option, and the evidence for all other things are very preliminary, and they should be taken, as the English says, with a pinch of salt at the moment. So thank you very much for your attention. I'll be happy to take if there are any questions.
Thank you so much, Professor Ahmad. Thank you so much, Professor Ahmad. This was a very elaborative talk, and I'm sure the concepts are very well taken and understood. If we may ask you कि आप इस किस्म के treatments में progression और survival किस तरह से देखते हैं, and what are the possibilities or probabilities that exist?
So the question is that for patients who have failed BCG treatment, what are the chances of these newer modalities to work? Really, these are alternative options which have very limited, or at best at the moment, 1 year improvement in progression of the disease. So we need to really wait for some long-term results to call them close to radical cystectomy in the management of these cases. So I still consider that cystectomy, if indicated because the patient has failed BCG, is something that should be done timely in order to save the disease moving out of the bladder and becoming metastatic. And then it's a very difficult condition to treat. We have seen patients dying. Professor Bridges has a raised hand.
I raised a finger. Well, Professor Ahmad, I totally agree with what you have been saying. The 3 cases that you presented in your presentation are definitely cases for cystectomy and not for BCG or whatever. So I agree with that. And although I also discussed some alternative treatments, we do have to realize that, you know, the best prognosis you will get with radical cystectomy, and yes, we will do sometimes radical cystectomy in the patients that might have profited from something else. And yes, there is, you know, a little bit more demand for bladder preservation, but we shouldn't play around with the life of patients. And cystectomy is a good option. And you also see in those studies that, you know, then patients can go in a study if they are unfit or unwilling to have a cystectomy. I never had a patient that was unwilling, and I seldomly have a patient that is unfit. You know, if you have a good hospital and a good operation, it is a, you know, it's not a minor operation, it's a major operation, but still, I think you stressed quite elegantly that the way to go is actually cystectomy. So that's what I wanted to say.
Thank you.
Okay. What is your experience regarding immunotherapy for bladder cancer?
It should go to Professor Bridges because I have no personal experience of use of immunotherapy. I mean, besides BCG, you mean, right? So I have no practical experience of these agents.
Okay.
So we've been involved and are still involved in some of these trials, and realize if you go into a trial like that, we now have a trial with nivolumab, which means that you will have systemic nivolumab every 3 weeks for a whole year. In that trial, it is even combined with a oral drug or with BCG. So, and yes, you know, if you profit, the chance that you will profit is around 25%. That's it. So 75% of these patients will probably still have their tumor somewhere during that year or after that year and still have to have a cystectomy. And you're lucky if you are within those 25%. You don't know what happens after that. And even if you are within those 25%, it's a quite intense treatment burden. And sure, in a trial, it's even worse. You have to have scans and more. You have to have all kinds of stuff. But even if you're not in the trial, realize that systemic treatment is every 3 or 4 weeks an infusion, still bladder checkup. It's quite intense. And that's one of the advantages of nadofaragene. That's one instillation every 3 months, which is for a urologist very convenient. And in this case, if you give immunotherapy, pembro or nivolumab, I guess you have to cooperate with your medical oncologist because they do that part and you have to do then the intravesical part. So for a patient, it is quite a treatment burden. And, you know, well, what I said in my presentation, I don't know what we'll be doing in 5 years. Whether this is going to be a major setup, I don't know. We know from the States that pembro isn't used a lot in these patients. And I think I can understand why.
One of the major problems in Pakistan setup is that because there is very little support available in terms of the insurance companies, so patients have to really pay from their pocket in order to pay for these things. And with kind of extensive follow-up required, and they have to be really religious in terms of their follow-up, the cost of their medicine as well. It's all very difficult in at least our part of the world at the moment.
Yeah, you know, so apart from the practical points, you indeed have to cost it. It's very expensive. It's around 4,000 to 5,000 euros per month. So, you know, that's major. So maybe it's not even going to be reimbursed in Europe. I don't know. And I know in the States it is partly reimbursed. It's a lot of out of pocket payment. It's a lot of money.
Yeah.
Okay, that's you know, in terms of magnitude, that's huge. That's very big. So now moving forward, just a reminder for CME creditors, you can find that link on your screens and can connect through that. And we'll be inviting Dr. Hafiz Qureshi, who's the head of urology at Indus Hospital, Karachi. And he will be talking about the recent advances in the diagnosis and treatment of non-muscle invasive bladder cancer. So, Assalamu alaikum, Dr. Hafiz.
Walaikum salam. Can you hear me?
Yes, we can hear you.
Yeah.
बहुत शुक्रिया
So,
आप वक्त निकाल सके.
Thank you so much. It was a very detailed presentation by Professor Hamad Attar regarding the recent the advances as well. So I have some of slides which I will be discussing here. And thank you very much, Professor Vijis, because he had a very detailed presentation as well. So I just missed because of some the error in the internet connection. So I would like to start with something about the recent advances. So go next slide, please. So I would like to have some.
Professor Vijis and Professor Hamad, they elaborated their topics so comprehensively that, you know, the questions that were coming in your mind were, you know, automatically addressed on the latest slides. I mean, I can't thank them enough.
Yeah, thank you so much. So here I would like to start with my objectives, that I would like to give some introduction about the bladder cancer, which already have been done, while some newer modalities in the diagnosis, and then recent advances in the management of the non-muscle invasive bladder cancer. So here I would start with this is one of the commonest malignancy of the urinary tract, while incidence is much more common in the men than the women. While about the 75% of the patient who have the bladder cancer, usually they have the superficial bladder cancer. So, and the CIS, which is a carcinoma in situ, is the cancer which is the high risk cancer. Next slide, please. So whenever the patient who comes in our clinic, usually have the history of hematuria, and then we diagnose as a bladder cancer. We start with the cystoscopy and we do the TURBT to reach the histopathology. And then we stage the patient, either it's a superficial or the muscle invasive bladder cancer. And then we opt for the treatment options. So while the non-muscle invasive bladder cancers, they are usually can be treated with the radical TURBT, which is the bladder preserving approaches. And then if the patient who have the non-muscle invasive bladder cancer, we already opt for the options like the mitomycin or the BCG, which is the immunotherapy. While those patients who have the CIS, which is carcinoma in situ and high-risk T1 disease, and those are refractory to the BCG, as mentioned by the Professor Hamad Athar, that these patients can undergo for the radical cystectomy. Okay, go ahead. So this is one of the pictorial presentation. If we look from the left side of our present picture, that is starting from the lower side, it's a superficial tumors. Then with the progressive on the right side, the arrow shows that it can be the T1 disease, which is an invasion to the lamina propria, then it invades in the muscular layer, and then it invades to the perivesical space, and then becomes advanced as a spreading to the adjacent organs. Go ahead. Then coming towards the urinary based markers, which is the new modalities, is still under the discussion. While there another thing, which is a photodynamic diagnosis, which is blue light cystoscopy. And then third one is a neuroband imaging cystoscopy. Go ahead. So if I would like to give some the detailed discussion regarding the urinary markers, they have the higher sensitivity, but have the lower specificity. If you compare with the cytology, urine cytology, which have the much more sensitivity. While there are the many urinary markers have been developed, but still none of these markers have been accepted in our routine practice. While certain benign conditions like the inflammation or the BCG installation, they may alter the results of these urinary markers. Go ahead. So if I look the sensitivity and specificity of the urinary markers, they usually depends upon the clinical conditions. Whatever you want to look in the patient, either you are going for the screening, either you are looking for the primary detection of the disease, or your follow-up for the patients. While these urinary biomarkers can be used as adjunct to the cystoscopy to detect the missed tumors, particularly CIS. So this is again from the European urology guidelines that according to this current knowledge that no urinary markers can replace the cystoscopy during the follow-up or lower cystoscopy frequency in a routine fashion. Next, please. So this is the list of the urinary markers which are in our literature. We are starting from aneuploidy, and then every urinary markers they are a little bit expensive and they need much more work to detect these urinary markers. And but have the different sensitivity. But if you look the lower one like NMP22 and then the lower one surviving, they have the low sensitivity. So still there are a lot of debate about these urinary markers. Go ahead. Next, please. So again, going towards the blue light cystoscopy and are the photodynamic. These patients, if you plan to have the blue light cystoscopy, there is certain indication for going to do this blue light cystoscopy. Like those patients who have the positive cytology, but they have the negative white light cystoscopy, which we do there as a conventional cystoscopy, or the initial follow-up the patient who have the CIS or the multifocal tumors. What we do in these patients, about 30 minutes before, we put the 5-amino-levulinic acid or hexa-amino-levulinic acid in the ward and before shifting into the OR. And then after the 30 minutes, we ask the patient to come in the OR and we do the cystoscopy. It is a specialized type of the cystoscopy, which is have the specialized light and that system which have the white light. And once you turn on to look these lesions, you just turn on the light, which is a blue light, which can give you the idea about the suspicious lesions. And from their suspicious lesions, you can do the TURBT, you can do the biopsy of these lesions. Next, please. So there are the different systemic reviews and meta-analysis regarding the blue light cystoscopy that have the highest sensitivity than the white light. And at the both patient level, which is 92 versus the 71%, and the biopsy level. As I told you that these lesions which are missed by the white light cystoscopy then can be visualized by using the blue light cystoscopy. And the blue light cystoscopy has the lower specificity than the white light. While coming toward the false positivity can be induced by the inflammation of the patient who have the recent TUR or during the first 3 months of the BCG installation. I have been the experience regarding the blue light cystoscopy when I was at the Red Board, that the patients were shifted in the OR, and then there's a specific the monitor which have the setting that you can put the setting on the blue light, and you can visualize the lesions which are not visualized on the conventional cystoscopy. So next, please. Next, please. Yes. So the narrowband imaging, another modality is there for the looking the tumors which are not visualized with a simple cystoscopy. But in this, there's no need to use the dye. It can be used as doing the flexible cystoscopy, and this is the mechanism for that. It penetrates the depth of the bladder wall with this the specific light, and which can visualize the superficial bladder tumors, while it enhances the structure of the bladder mucosal wall. It improves the detection of the recurrent non-muscle invasive bladder cancers. So this is the article which have shown that the narrowband imaging cystoscopy in the non-muscle invasive bladder cancer, that the overall detection rate for this non-muscle invasive and the carcinoma in situ were significantly improved by using the NBI, which is 96 versus the 87%, and 100 versus 67%. So the another study which is from the China that shows the detection of the bladder cancer by the NBI, and this is the meta-analysis that shows the NBI cystoscopy is accurate with the high diagnostic precision for the diagnosis of the bladder cancer. Go ahead, next please. So by going towards the treatment of non-muscle invasive bladder cancer, as the Professor Hamad have discussed and Professor Vijay have discussed, that these are all the normal, which conventionally we treat the patient by doing the mitomycin or doing the BCG treatment. Here I would like to give some different options which improving the intravesical chemotherapy, like the device assisted methods, either by using the microwave induced hyperthermia or the EMDA or the hyperthermic intravesical chemotherapy. Go ahead. So what is the microwave induced hyperthermia? That it uses the microwave radiation in this frequency, and it raises the temperature of the tumor to the hyperthermic range around 42 to 43 degrees centigrade. So these microwave, the inside the bladder, it generates the heat. And by generating this heat, which is a hyperthermia, which causes increased sensitivity of the tumor cells by the hyperthermic, by the hyperthermia, and causes sensitization of the chemotherapy drugs. The data shows improved efficacy of the mitomycin by using microwave-induced hyperthermia for high-risk tumors. One of the randomized control trial, which comparing the 1 year of the BCG with 1 year of mitomycin and microwave-induced hyperthermia in intermediate to high risk, which increases the risk, the 24 months, the progression-free survival, and in the mitomycin group as compared to this one. So these are the two pictures which I took from the Red Board Hospital. This is the left side, which you can see is a specialized catheter, which have the probe at the tip. And this is connected with the right side. There's a monitor which is having the setting. And on the right side of there's a monitor, and the left side, you can see it's a generator which is connected with this the solution which have the mitomycin, and it pumps, because the drug that circulates in the bladder from one catheter end, and then like a hemodialysis machine, we have a pump that pumps the blood out of the patient and then get filtered and then go into the patient's body. So this is like there's a pump system which causes the flow of this same drug with a specified temperature. Go ahead. So coming towards electromagnetic drug administration, EMD also uses the electric current to enhance the transepithelial drug penetration. The mechanism of all the device-assisted methods are almost same, either by doing EMDA, either using by microwave or by generating the heat. So again, it causes the increase the penetration of these transepithelial by the drug. So the administration via the battery-powered generator, which is delivering the current, which is 0 to 30, while this current passes between the two electrodes. An active electrode is placed in the bladder as a part of transurethral catheter, and dispersive ground electrode with pad which are placed at the skin of the lower abdomen. So this is again the mechanism of this one. So this was the same sequential BCG and electromotive mitomycin and BCG alone with a high-risk superficial bladder cancer, a randomized control trial. It was discussed by Professor Hamad that same month the BCG followed by the electromotive drug administration of MMC result in a higher disease-free survival and improved overall survival and disease-specific survival compared to the BCG alone. So this was the same thing. The sequential, we can improve the efficacy of these drugs. So this again, the pictorial presentation. As I told you, there's a generator, and there's the negative, the plate which is placed over the patient's abdomen, lower abdomen, and there's a specialized catheter which is introduced in the bladder, and which generate the current and which produces the heat, and this causes increased efficacy of the chemotherapeutic drug. Next, please. So coming to hyperthermic intravesical chemotherapy, it is one of the become the part of the standard therapy, and it is routinely practiced at the hospital, at the Redwood Hospital, where I just had exposure of this, how the process they are doing over there. It's one of the outpatient clinic procedure they do in a specialized. There is a nurse over there, a specialized room, and this total they are doing with the confidence. So it's one of the part of the standard therapy for the high-risk non-muscle invasive bladder cancer patients who have the recurrent tumors and who are unsuitable for the radical cystectomy, or who have some contraindication for the BCG therapy. Like hyperthermia, which induces the cell killing, which is called cytotoxicity, after the blood flow and make the tumor microenvironment hypoxic and acidic, further increasing the sensitivity of the cells to both heat and the cytotoxic therapeutics. Go ahead. So this is again the paper which is published by the Professor Wages, and that shows that role of combined regime with the intravesical chemotherapy and hyperthermia in the management of the non-muscle invasive bladder cancer. It's a systemic review. So it shows that a 59% relative reduction in the non-muscle invasive bladder cancer recurrence when the mitomycin uses with the hyperthermia as compared to with the mitomycin alone. Thank you so much. This is the picture with my Professor Wages when I was there. Thank you so much.
Thank you, Dr. Hafiz, and thank you for the elaborative presentation.
And the beautiful last picture.
Yeah. So,
thank you, sir.
You know, any comments from you, Professor Wages?
No, not so far. Abdul talked about enhanced imaging. I've been involved in blue light since beginning of the century. The reason is quite simple. I'm colorblind, and I used to work with 5-ALA, and I didn't see the difference. And then the company Photocure said, well, Hexfix is better than 5-ALA, so we will try with whether he sees that. And I don't see the color, but I do see the difference. And I indeed think that for a better diagnosis, blue light certainly gives you additional tumors. And we also have NBI, and maybe because I'm colorblind, I don't see a lot more with NBI. So for me personally, blue light with Hexil 5-ALA, so with Hexfix or Cysview, certainly improves my resection techniques. I've learned by using 5-ALA or Hexil 5-ALA, I learned to do a better resection, to look better at the margins of your resection. So it really has helped me to improve my TOR skills. And the advantage of NBI is that you can also use that on the outpatients. And that's something that you cannot do with blue light. So there is also an advantage of NBI. But I personally don't see a lot of difference. But that might be my problem because, again, I'm colorblind.
Okay. Okay. I think there's a question we have that's related to your presentation and about the study that you mentioned. SWAG 8710 showed a 74-month median survival for patients receiving chemotherapy compared to the control arm, which had 43.2-month median survival. So new adjuvant chemotherapy showed a survival benefit across all grades and stages, with the greatest observed benefit being in T3 disease. Do you recommend adjuvant for T3 and higher?
Yeah. So again, the word already says it, the trial is from 1987. It is with MVAC, so it's a different way of operation. It's a different way of chemotherapy. Like I said in my presentation, I think in 2021, most people will use GemCis as neoadjuvant chemotherapy, which is without any doubt a little bit less effective than MVAC. Also much less toxic, by the way. And I do think, I've been operating now for 30 years. I really think that I hope that I do a better job now than I did 30 years ago. So like you say, you see the difference mainly in the higher stages, and there have been sub-analysis of these trials where you actually see that in T2 disease, there's almost no difference. And again, if you're at bad luck and you don't respond, you might even progress during neoadjuvant chemotherapy. So yes, in T2, I don't give neoadjuvant chemotherapy. In T3 or higher, which with the current CT technique, you can see quite well. So in T3 or T4 or maybe even locally advanced like N1, I tend to give neoadjuvant chemotherapy, yes.
Okay. Dr. Hafiz, is chemo hyperthermia the understanding available here in Pakistan?
No, I don't think so, because I don't think so, because we come across when I was in the Professor Vijay's, when it was my first experience when I saw all the system over there. But I think in Pakistan we don't have all these hyperthermic devices to enhance the efficacy of chemotherapy.
Okay. So I know that there are several countries, or a lot of countries, where this is not available. And you have also the system where you can only use actually maybe an infusion pump and just heat the fluid. Heating of the fluid is probably less effective than radio frequency induced, but it does improve a little bit. And I know Don Lamb very well. And what he does is he fills a catheter, the balloon of a catheter, with a fluid that is very hot. So he fills the balloon with fluid that is 60 degrees, and then uses insulation, so sort of automatically keeping the temperature as high as possible. So there are several ways to try to increase the temperature, because it sounds logical if you increase the temperature that your drug will have a higher efficacy because you will have more absorption in your bladder wall.
Okay. Professor Ahmad, any comments from you, please?
Well, in response to what Professor Vijay have been saying in his presentation, and subsequently in response to your question about neoadjuvant chemotherapy, I remember a paper published some years back in which the real life situation versus the randomized control trial situation have been compared. The real life situation is what Professor has been describing, that a lot of urologists still not very convinced that the approximate 50% response rate with neoadjuvant chemotherapy is at least delaying cystectomy beyond 3 months in the other 50% who are not responding to that chemotherapy. So you need to be very, very careful in terms of those patients who are going for a neoadjuvant, particularly elderly, who would have various hematological issues or infectious issues, and they would subsequently have a delay in their cystectomy, which is going to be more deleterious rather than the advantage that the other 50% will get with a neoadjuvant chemotherapy. In terms of various modification of radio frequency or EMDA or microwave, I'm aware, and there is literature, and I think this is something that, Hafiz, you can think in terms of starting a little trial and seeing that those patients who have not responded to BCG or who have failed BCG and who do not want cystectomy, and since we have very limited option for those group of patients, we can run a trial and see if some of the modified ways of administering intravesical treatment can have a role for a big population of the world where these techniques are not available and these equipments not available.
Would be a good idea.
Right, sir, right.
And can we foresee any collaboration whereby we can bring in these techniques here?
Yeah, I think you should try to cooperate. You should try what Professor Habat says, try to find a let's say, simple and logical way to provide a new device-assisted therapy. So with all respect, I use Senego, which is really very effective, but again, it is expensive and quite high-tech stuff. And I'm sure there are easier ways to do that. So you should try to think of a somewhat easier way and then profit from centers that have already a lot of experience and try to set up a collaboration with a center like that, certainly if you have a lot of those patients, it's really worthwhile. What I see with my Senego treatment, I really have saved a lot of patients that were sent to me because they were planned for cystectomy, and a lot of those still have their bladder. And of course, it's not a panacea, it's not a miracle, but still more than 50% of those patients, I still have a lot of them that still have their bladder. So that's good, that's nice.
Yep.
When we specifically talk of bladder tumors, so does race play an important role in determining it?
Sorry,
well, what you see is that women usually come a little bit later, because if men void blood, that's an alarm symptom. Females are used to having blood below there. We don't. So they're usually a little bit later. But even if you correct for delay in diagnosis with the same stage, males have a better prognosis than females. And like I said, maybe that's because our bladder wall is much thicker than those of females. So, and like Professor Hamad suggested, shouldn't we do that? Shouldn't we put that in the guideline? It's not in, but we all have to realize that women do worse than males. So it's for me personally, it's an extra factor to decide on more aggressive therapy. If there is a lady with a T1G3 plus CIS, I think I would advise cystectomy. If it's a male with T1G3 CIS, I probably would go for BCG. So, and that's not black and white, but it certainly, there is a difference.
And does ethnic origin has a role?
Sorry?
Like South Asians versus Caucasians? Ethnic origin?
Okay.
Does that differentiate?
We don't have that much ethnical differences in the Netherlands. We have, of course, some people from the north of Africa. And I don't think they have another prognosis. In the Netherlands, I don't think there's a difference. From the United States, that the Black population also has less access to healthcare, unfortunately. So that might be an issue. We don't have that problem in the Netherlands. So I can't answer that question, to be honest.
Yeah, I agree. I mean, if you look at the geographical distribution, yes. If you look at Europe, after the Industrial Revolution, there was a big surge in the number of bladder cancer. We know that Egypt and those who are in the schistosomiasis belt have a high incidence of bladder cancer. But it's not like prostate cancer that the Afro-Americans are worse with the same stage and grade of disease compared to the Caucasian. So I think that kind of a difference does not exist for bladder cancer.
I agree.
Okay. So any final comments from each one of you and any feedback in general? Then we'll move towards closing of this session.
Well, for me, and then I will summarize my lecture and that of Professor Hamad. Don't wait too long with the cystectomy. So, all kinds of alternative treatments are great, but cystectomy is actually the most effective therapy. So don't get enthusiastic about all kinds of alternative stuff.
All right.
Be in time with the cystectomy. And thanks for a great session and for the invitation.
Yeah,
thank you for being here.
Thank you very much.
Thank you so much, Professor Hamad, for your valuable time. And thank you, Professor Regis. I'm very much happy to see you after a long time because it was a nice time which I spent with you. Thank you so much. And thank you. Okay.
You're welcome.
Okay.
Professor Hamad, any final words from you, please?
Well, I think one very important lesson for us is that TUR is the cornerstone of the management of bladder cancer. Don't give it to the junior most staff member of your department and expect to do all the fancy stuff yourself. If that diagnosis is not correctly made, if that first step is not appropriately taken, you will regret it throughout. So the key is a good TUR, be there or do it yourself, and make sure that every bit of tumor is removed and you know exactly what is inside the bladder.
Okay. Okay. Thank you so much. आप तमाम लोगों का बहुत शुक्रिया for taking out time and being a part of this show. In future, we also foresee, you know, different topics coming up where we can collaborate and where we can seek your inputs, and we'll be looking forward. Our audience has already, you know, given such amazing comments about the presentations that we have had, that they have been so elaborative, and they will definitely help them in their clinical practices. Having said this, I would, you know, like all of you to be stay tuned to ICIP thinkhealth.com.pk. This is a site where, you know, you can understand the agenda and the talkathons that we are going to have for these 2 weeks with different academic topics. So it's icipthinkhealth.com. You can sign up here and look for the upcoming future programs, which we are bringing in on daily basis for the next 1 week. Thank you so much, Professor Dr. Fred Pittis. Thank you so much, Professor Dr. Hamad Athar. It's always very difficult to, you know, take time from you two, but it's an honor and a privilege that you were a part of it. And especially Dr. Hafiz Qureshi Saab, he's, you know, in very simple words, he is the most available surgeon, not just for a pharmaceutical concern, but for his patients as well. The way that he deals with his patients, the way that he elaborates and gives time to his audience and patients has been remarkable. Thank you so much. आप लोग अपने गिरदो नवा में अपने चाहने वालों जाने वालों का ख्याल रखिएगा और कोविड की इस वेव में stay safe. Thanking you all. Goodbye and Allah Hafiz.
Thank you.
Bye-bye.